TopMedTalk.
Hello and welcome. I'm Monty, Mythen, Editor-in-Chief of TopMedTalk, and I'm coming to you live from the Evidence-Based Perioperative Medicine, that's the EBPOM pop-up studios here in London, in advance of us going live with EBPOM USA, virtually live from Chicago, coming up shortly. Now, I'm joined by co-host, Professor Mike Grocott, who's very familiar on TopMedTalk, who's actually standing in at the moment for Desiree Chappell, because we managed to get hold of a special guest at short notice. So I'm guessing we haven't been able to get hold of her. We haven't tried to get hold of her because I think it's about 4 o'clock in the morning for Desiree at the moment. So Mike, we're at risk of being shouted out as being a manel, but thank you very much for being our contributor to this particular panel at short notice. How are you, Mike?
I'm very good. It's a delight to be here, and I'm a pale reflection of Desiree, but I'll do my best.
So, Desiree, we apologise for having to crack on with this at short notice. So, Mike, we're here getting ready for our second virtual EBPOM meeting, and this one is going to be virtually live from Chicago in the USA. So, a quick update for everybody as to how we got to this point, why we're doing this.
Well, I guess we're in this extraordinary year with the COVID-19 pandemic. In the UK, we look like, although the government are desperately trying to brand it otherwise, we're kind of heading back into a lockdown type situation with meetings of more than 6 people not allowed from next week. And so all the normal meeting activity that we've done over the years for EBPOM is just not possible. And of course, we had the extraordinary success of EBPOM in London in July, which I think surprised us all, but was really gratifying to see so many people logging in to that meeting.
So great congratulations to everyone. So in London, about 8,000 or so people turned up, and our total logins now for our EBPOM meetings are up around sort of 12,000 or so. And our downloads for our free open access medical education podcast are just about to hit the 1 million downloads. So, thanks to everyone who supports us. It's great that we can continue to bring information to the world free at point of use, and we couldn't do that without all of our generous different sponsors. So, Mike, how do you think, we should probably introduce ourselves. Not everyone's not going to notice. This is going to go out as part of the pre-records for the EBPOM meeting. I'm a professor of anaesthesia and critical care at University College London. Now, Mike, you're from Southampton, but you also have been on our news quite a lot recently because you have a national role or roles as well. So what else do you do?
Like you, I'm a professor of anaesthesia critical care in Southampton, but I've also, like you, served on college council. So I have the Royal College of Anaesthetists Council for the last few years and was lucky enough to be elected as vice president last year, which ended up obviously being the year of COVID. And in fact, my term has been extended as a result of that because we couldn't run elections a few months ago. And so I was drawn into a lot of COVID-related activity, particularly, and I think really importantly, that the health messaging about the burden on the NHS and the burden on intensive care units in particular, and the importance of social distancing when we first started doing lockdown. And I think contrary to what our government and a lot of people expected, we had extraordinarily good compliance with the requests to stay home and not go out for months on end in the UK. And it's only really been the last couple of months over the summer that people have had anything like a normal life. And even that's been very different from what we might have had in other years.
So now we've got the complexities of winter is coming literally, but also from sort of Game of Thrones perspective, winter in the form of the second surge of COVID might be coming. At the same time, as we're all trying to completely reboot our regular health service, and in particular completely reboot all forms of elective surgery. So this meeting, Evidence-Based Perioperative Medicine, is really about getting people completely prepared for surgery, try and fix everything we can fix, to try and use enhanced recovery principles to get people drinking, eating, mobilizing within a few hours after surgery, and to get people home as quickly as possible when they're ready to go home. You're a great champion of that, Mike, and your centre practices many, if not all, of those elements of it.
We do, or I would say we did and we will, but it's been extraordinarily challenging. I'm not sure how it's been in other countries around the world. I know some experience has been similar to ours, but we pretty much shut down elective surgery in many centres through April and May, and then gradually had a restoration period over June, July. But there are a whole variety of problems. There's a backlog of screening, so some of the cancer surgery isn't happening because we're probably not diagnosing some of the cancers. There's a backlog of major surgical procedures, including cancer surgeries, and a lot of the number of activity around surgery, so all the perioperative care, the post-operative care, is really struggling to get going because of some of the challenges of aerosol-generating procedures, because of a lot of staffing issues. A huge number of people worked a lot, in an extraordinary amount during April, May, June, and therefore we've had lots of people on leave over the summer because we need them back again for what we anticipate, and it now looks as though it will transpire, will be a resurge of some magnitude in the autumn. So at the moment, we're really struggling to do what we would like to do, and we're hopeful that at some point, maybe next year, we'll start to reboot all those services.
So in rebooting those services, I'm going to load this now because of our very special guest. One of the things that has been on the list with preoperative preparation for quite a number of years now has been the treatment of preoperative anemia, very much interpreted by people as being low-hanging fruit. Why wouldn't you try to fix anemia? And with the availability of intravenous iron, tremendous enthusiasm for treating anemia preoperatively, with many people, based on their personal experiences, sort of turning around and says, well, we tried it and it worked. And I think many of us are in that camp, and I think you're in that camp locally. I think you have an anemia service. I heard your colleagues talk about it, and I think you deem it to be very successful.
Yeah, no, it's been the poster child, anemia management, of the whole broader spectrum of comorbidity and long-term condition management around the time of surgery. And we all, inverted commas, knew it worked. Now, some of that is based on experience of implementing services and changes in, for example, blood use. But you can't tell at a single centre at those sort of number levels. You can't be sure that it's improving outcomes. So, the big randomised controlled trials are very important, and the results of big randomised controlled trials should be colouring how we behave. So I think, were there a big randomised controlled trial related to anemia management, for example, we would have to reflect very carefully on
right.
that trial.
So time to introduce our very special guest, Professor Toby Richards. So Toby, where are you joining us from?
I'm at Perth in Western Australia. I'm at Fiona Stanley Hospital here.
Toby, we were colleagues at University College London. We've all been colleagues back in the UK, and sadly, we lost you to Australia. Lucky them, relatively recently. But I'm going to give you the executive rapid version of it in the interest of time. You're a vascular surgeon. You became a full professor at UCL. You're also well known as being very interested in perioperative medicine and one of the global leaders in the recognition and treatment and management of anemia. And indeed, we've interviewed you a few times on TopMedTalk. Desiree is going to be very sad to be missing this sort of climax of what we've been building up to over the years. And I think you've always been very interested in anemia. I think you think it's important. You think it can be important to treat it. But you very, very boldly set out a number of years ago to do a large prospective randomized controlled trial. Now, many people have heard the results of that in the last few days or weeks. If you could sketch out for us the trial design.
Thanks, Monty. I'm delighted to speak with you again on TopMed. The background to this is my training as a vascular and transplant surgeon. And so I was exposed when doing liver and kidney and pancreas transplants, particularly kidney transplants, to the utilization of EPO and intravenous iron to correct anemia. And to me, it made logical common sense that if you're about to undergo major surgery, which is effectively running a marathon, the better physical shape you're in before you undertake that insult, the better you're going to do. It seemed to make sense. And one of the most common things we see in vascular surgery, where we have really quite sick patients with multiple comorbidities, is this anemia of chronic disease, whatever that may be. And so my question was, well, can we actually optimize these people, feed them, enhance recovery, correct the anemia, and will they therefore do better after surgery? And that's where it came from. That's where the ideas came from. Now, with regards to the PREVENT trial, this started a decade ago with our publication in The Lancet in 2011, where we showed a linear correlation between preoperative hemoglobin levels and postoperative complications and mortality. And that was the US Veterans Database, NSQIP. And it was a meta-analysis and multivariate analysis. So that's since got reproduced by around about 27, 28 separate cohort studies, all saying the same thing, including our own prospective data. So there's an association between anemia and need for more blood at the time of surgery. Those people who are anemic spend longer in hospital, an average of 9 days compared to 6 days, and overall have a worse outcome at long-term follow-up. So the question was, if you can correct that anemia, do you correct that risk that has been associated with anemia?
And then, Toby, to interrupt for a second, sorry, the big paradigm shift for all of us was the switch from tablets to IV, I think that generated the great enthusiasm in the what next. Can you just touch on that for a moment?
Timing was also excellent because in 2009 and then a couple of years later, newer preparations of intravenous iron came out. These preparations enabled clinicians to give a total dose iron infusion of 1,000 milligrams or more as one infusion safely in 15 to 30 minutes. And I thought this was a complete game changer. It was they were non-dextran ions, so there was no associated risk of anaphylaxis or risk that was the same as for an ordinary antibiotic. And if you are so iron deficient to the point of anemia, you're around about 1,000, 1,300 milligrams of iron behind. So this could have been, or could be, the answer to surgical anemia.
And that's like a year's worth of iron is what I've always taken away from that. That's like...
Yeah, absolutely. For a normal human being without excessive blood loss, you need about 2 to 3 milligrams a day, so about 1,000 milligrams over a year.
And a lot of people, we've done this with podcasts with you before, a lot of people taking tablets, not only do the tablets not get the iron in very successfully, they do in some people, but for a lot of people, they just make them feel unwell and they don't actually get much iron into the body.
Yeah, absolutely. If you can absorb iron, and many people cannot, you absorb about 150 to 200 milligrams a month in total, no matter what dose you take.
So you thought, well, okay, this is a good idea. I think we were all jumping on the bandwagon because it was one of those sort of, do we really need a prospective randomized controlled trial? Isn't this a bit like the parachute? It's broken, you can fix it. That must be a good thing. But you decided to do the big trial.
Yes, so this is going back 10 years before intravenous iron essentially became a common drug utilized by many people. And so the population was patients undergoing major abdominal surgery. And we chose open surgery because we wanted the most rich population where you're going to see the greatest effect. So major open surgery, such as an open esophagogastrectomy, hepatectomy, Whipples, etc., on average, 40% of people were getting transfused. And if you looked at laparoscopic surgery, it was a reduction of threefold. So the intervention of laparoscopic surgery has made phenomenal differences in the last decade in surgical practice. And I'm sure that could be a separate conversation. But if you wanted to power a study for a baseline transfusion rate of 15% to reduce it to 10%, you'll need thousands of people. Whereas we powered this study to reduce transfusion by 14%, so from 40% down to 25%. And we would require 500 people. And the argument when we talked to the HTA about including laparoscopic was, well, if it ain't going to work in this group, it isn't going to work in any other group. And also, if your number needed to treat crosses 30, are you really going to treat 30 people to prevent one blood transfusion? So there's got to be a sense of reality and plausibility in what you're doing.
So it's adult surgical patients undergoing major open surgeries with caveats with regards to anemia and indications for treatment. Multi-center, as I understand, exclusively UK based?
It was a UK-based trial, multi-center in 46 sites, of which 42 sites recruited. The inclusion criteria was anemia as defined by the World Health Organization, so hemoglobin less than 12 or less than 13 for women and for men. Now, The interesting thing is that we've looked extensively at the causality of anemia in the preoperative setting. I had a fellow who sat in the PREVENT audit and undertook bloods looking at ferritin levels and transferrin saturations in 1,500 people at UCH, and it's all over the place. You cannot actually sensibly predict the causality of anemia in that group. Now, the other thing we also did was in cardiac surgery, we did every blood test you can possibly think of, serum transferrin receptors, zinc protoporphyrins, including bone marrows. And again, the underlying causality for the anemia didn't predict the outcome in those cohort studies. So therefore, we chose anemia, which is where the data was, to be the inclusion criteria, but we had a predefined subgroup based on ferritin and transferrin saturations.
And the people who are into the who are subspecialists in the area, into the fine print, I'm guessing in follow-up discussions, that's going to be part of the what if, but I do X, I do Y. We're not going to go there at the moment because we're going to get to the headline results. And we promise we'll, when people have had a chance to absorb all of this and think about it, and everyone's got out their problem lists and the I believe lists, we'll have a follow-up. So total numbers recruited, you said, were around...
We recruited 487 people over a 4-year period.
So that gave you the power, enough of the power you were looking for to address your primary outcome variable. And your primary outcome?
Now, the primary outcome was whether or not you were transfused or died, because death was a confounder, so we included that as the co-primary, and the number of transfusion episodes, so how often you got transfused. So they were co-primary endpoints. They were deliberately designed to be pragmatic because as a surgeon, you either transfuse someone or you don't. And you either transfuse them once, twice, or 3 times, or you don't. And it allows for the variability of, you know, when the junior doctors are on the ward round and they see someone with a hemoglobin of 67, and the knee jerk is to give 2 units of blood, which we all know is the real practice. So there's one decision, although there were 2 units of blood given. And that's why we chose those primary endpoints. The secondary endpoints included average numbers and total numbers of blood, etc.
So, drum roll, for those who haven't read the paper or haven't been tracking the Twitter sphere and the whatever way you get your information, drum roll, the big answer is...
we saw absolutely no difference whatsoever between the groups in the intention to treat analysis. Those people who received intravenous iron, there were 69 transfusions compared to those people who received placebo, and that was 67. There was no difference in any of the predefined subgroups, and that was hemoglobin less than 10, elderly defined as age over 75, and ferritin less than 100. Also, the per protocol analysis made no material difference to the results whatsoever.
So now there's going to be a long list of caveats and ifs and buts, and it took a long period of time and a highly selected population and But at the end of the day, there's not a sniff of a difference there, Toby. It's not one of those things where you have that tantalizing, we were talking a little bit earlier, the sort of, let's call it the Pierce result, where you get where you get quite a big difference and a p-value of 0.58 or something like that. It's there's not a sniff, is there?
No, I mean, look, I've built my entire career on thinking this was the best thing since sliced bread, the silver bullet, the magic wand. I really thought that intravenous iron was going to be the answer for surgical practice. So once I'd overcome my alcoholism, my depression and disbelief, I've had to go back and look at these data, and the way you write up a trial for the HTA is a very formalized manner.
So we should sorry to interrupt, we should clarify, not everyone's going to know the abbreviation HTA.
Fine. So the government funding body requires a specific format for the way in which you write up the trial. Yeah. That's a far longer document than the document in the Lancet, and it has to be done exactly as per the consort guidelines. And sticking to that scientific rigmarole was quite helpful, because it makes you go back and look at the population. So was the population the correct population? And the answer is yes. These people were having big operations. The average surgical time was 2 to 3 hours, and the average anesthetic time was 4 to 5 hours. A good proportion of people went to intensive care post-operatively, and there was an even spread between esophagogastrectomies, hepatectomies, hysterectomies, and I mean Wertheim hysterectomies, not just a simple transabdominal, Whipple's procedure, and open colectomies or abdominoperineal excisions. These were big operations. The usual risk factors of diabetes, cardiac disease, etc. So I'm very happy with the population. The intervention was administered in a double-blind manner. So it was a completely separate team to the research team and the clinical team who administered this. The iron, which is a dark brown solution, was prepared outside the room in a black bag with black tubing. We used iodine on the skin, and so the patients had no idea what they were getting. And in fact, we actually asked them what they thought they were getting randomized to, and the vast majority had no idea at all. There was a bit of guesswork, but the vast majority said they had no idea what they got. Importantly, the intervention was planned 10 to 42 days prior to surgery. And in all the pilot data, you should see a 75% efficacy of the intervention. So intravenous iron should cause an arthrogenic response within 5 days, and you should see 75% of that response within 10 days. And it was an average of 15 days prior to surgery with a quite tight confidence around that. The control, as I say, was blinded. So I'm very, very happy with the conduct of the trial. And the interesting thing is when you look at the outcomes, yes, I've talked about blood transfusion, but quite honestly, as a surgeon, as an anaesthetist, we don't really mind that much about blood transfusion. There's this belief that blood is bad, but actually, it's probably like any other intervention. If you use it appropriately, it's appropriate. If you use it inappropriately, you will have side effects. But the key point was the secondary endpoints. There was no difference in length of stay in hospital between the two groups, none whatsoever. It was an average of 9 days. There was no difference in the Clavien-Dindo complication rate. It was virtually numerically identical, whether or not you include grade 1 to 5 or just grade 3, 4, 5, the severe complications. And there was no difference in days alive and out of hospital either. So in the key primary and secondary endpoints, there was nothing, absolutely nothing. And so in answer to the question, in people who are anemia prior to major surgery, does intravenous iron correct that anemia and therefore correct the associated risk of anemia to the patient, such as blood transfusion, length of hospital stay, and complications? And the answer to that question from the PREVENT trial is no, it does not.
Congratulations on finishing the trial. I know it's a long, hard slog. So, many people would have given up. So, well done to you and everyone who's been involved in the whole journey. So I'm just going to switch to Mike for a second. Briefly, Mike, your initial reaction. I know we've, by default, known the headline results for quite a long time, because of the various different behind closed doors meetings we get to attend with Toby and others. What do you make of it, Mike? What next?
I mean, as Toby says, Toby's had a longer journey with anemia than I have, and it's not what we all expected. It will be important that those who wish to understand the trial in more detail try and rationalise why that might be. But as you rightly comment, there's not a flicker of a response. It's not one of those borderline answers, and I think it should cause us to reflect on what we're doing with our anemia clinics now. Whether they are, are the clinics different from what was in the trial? We need to think that through, and that will be institution dependent. So there may be particular characteristics that means it is possible as benefit, but you've really got to work hard to persuade yourself in the face of a randomized controlled trial, proper experiment, well-conducted trial that says there is no difference at all. So I think there's a lot of serious thinking to do. I think the guideline writers are going to have to sharpen their pens for some more work. And I think there are really interesting discussions about why there may be differences. So, there may be some real signals in clinical practice, but mainly great trial. Well done, Toby. Congratulations to getting it published in the Lancet. And you've given us all a lot to think about.
That's plenty of work now. Mike, you're a leading clinical trialist in the world with many other colleagues. One response to a result like this is, it was a long time maturing. It's a single country. It's quite a selected group of patients. It's become a fairly mainstream treatment. And although it's a big trial, it's relatively small in modern days. Should we be now looking at the 20,000 patient pragmatic, many more types of patients undergoing surgeries to definitively try and answer the question? Or do we say, let's just do a lot of head scratching and relook at the guidelines, and people turn around and say, well, I'm not going to give it to those types of surgeries in Britain, but I'm going to give it to joint replacements in, America?
This is a non-answer, but I think we've got a lot of thinking to do. We've got high quality data. We need to reflect on it. Do all the going through the detail, pouring through the appendices, and undoubtedly there will be, people will respond with big observational studies, which will conflict. The results will conflict. But right now, I wouldn't say we've got to do a 20,000 or 30,000 patient study. Much as I'm an advocate for those studies, because typically you do need that kind of sample size to generate the power to show these effects. But number one, Toby deserves his moment in the sun.
he's going to get that.
It's an important result. I think merits reflection. I look forward to the future conversations.
Yeah.
Actually,
Toby, I'll let you come back in a second and respond to that, Toby. And as you do respond, I want you to add to that two components, what you think we may or may not do next with clinical trials or ongoing trials, which I know you've already shared some thoughts on that. But the other thing is, outside of the use in perioperative medicine, a lot of the work you went on to do in women's health in particular that was very impactful was how common anemia is, for example, in young women who have a vegan diet, who are at university, who are exercising, or who've had children recently. There's all of that mixed in with it. Are these two things confused? And Mike, I know you've got to go, Mike. Thanks very much for joining us.
I apologize. Great to see you, Toby, and to be part of this conversation, but I have a prior commitment, so look forward to talking again soon.
Yes.
Sorry, Toby, on those points.
So I think that iron deficiency is monumentally overlooked. It's the most common nutritional disorder in the world. It is the commonest cause of anemia, which is a top 10 WHO cause of disability, not of illness, disability. And it's a huge problem in low-income countries, and who knows whether or not this trial is relevant to that population where people are presenting with profound anemia, hemoglobins of 60 or 70. Now, in the setting of women's health, it is unquestionably beneficial. Oral iron is, without doubt, the first-line treatment, along with a good diet. But around about 25% of people won't respond to that. And if every other person in the world is female, 1 in 3 women will be iron deficient in their lifetime, and 25% of them don't respond. That's a big problem.
Yes.
And interestingly, in Australia, around about 2% of the population now have had an iron infusion. It's actually been raised as, are we giving too much?
Yes.
I would actually argue, say, no, based on the figures that I've just said, it should be more. And based on my personal experience, which is probably 6 or 7 years focusing on women's health, I'm getting into anecdotes and cohort studies, but it's a huge problem. And the intervention of intravenous iron really is that magic bullet that I was talking about and hoping about for the surgical patient.
I believe that, and I believe you, and I think that's but from what you've just shown us, if we did the large randomized controlled trial in that same group, might we get disappointed with the result, or do we not go there because it's kind of
No, I think that's a really good question. We have undertaken a trial and we're repeating it as a double-blind randomized controlled trial at this point in time. But it's a different population of patients, and the causality of anemia, for instance, in women's health could be nutritional, or it could be due to blood loss from heavy menstrual bleeding or pregnancy. Now, in that setting, it's an iron deficit disorder, in which case replacement of the deficit with iron will correct the disorder. Yeah. In the setting of the preoperative patient, I think the causality of the anemia is impacted by inflammation, whether or not that's from chronic disease or whether or not it's for the disease for which they're undergoing surgery. I don't know the answer to that. And internationally, we're not completely clear on what's the difference between anemia of chronic disease, functional iron deficiency, anemia of inflammation, whatever you may want to call it. We will be looking at that. We have all the lab experiments, etc., which have been done. Again, it addresses the question of, is the anemia seen in a sick person prior to surgery? Is that an association that's reflective of the illness that the patient has? And secondly, is that a risk factor that's correctable? You might be able to, there's definitely an association between anemia and outcomes. The question is, if you correct the anemia, does it correct that associated risk? And that's what we were really looking at in PREVENT. And the answer, unfortunately, is no.
So other trials and...
Yeah, other trials. So I think we also have to take away a key point from this trial. We have the COVID crisis, and our patients can be reassured that we're not disadvantaging them by not bringing them to a preoperative assessment clinic to give them iron. And actually, in 2020, that's probably one of the only good bits of news we've got going at the moment. So I think you have to look at the science for what it is. The second thing is that, as I keep saying, if everyone with an opinion enrolled one person into a clinical trial, there'll be no one with opinions anymore. And we have to believe in the data. That's why you have the conference, and that is why the audience is listening to this, because they want to listen to the data to influence their practice. And if nothing else, I urge people to enroll into clinical trials. If you have a patient, should they go into a steroid versus non-steroid trial? Should you be using tranexamic acid to help control blood pressure in POISE-3? And there are a plethora of clinical trials out there. And behind those clinical trials, there are people desperate to work with you in that regard. So please enroll to clinical trials. And particularly if you're a cardiac surgeon, the ITAX trial, where we're randomizing people prior to cardiac surgery to intravenous iron or placebo. The only way we're going to advance, and the only way, for instance, in the post-COVID era, as practice changes, are we going to be able to work out what's right and what's wrong, is by collecting data.
And ITAX is ITACCS, is it?
ITACS.
ATCS, and so it's iron therapy in adult cardiac surgery or something along those lines.
It's iron to treat anemia in cardiac surgery. It's an international trial based out of Australia. We're recruiting at 5 centres in the UK, Germany, South Africa, Malaysia, Canada. Come on, Canada, get going.
And how big is that going? We've interviewed Paul Miles about it before in passing briefly, but how big is that going to be?
So we're just over 500 people through to 1,000 destination. Okay. So yes, we urgently need sites to get up and going with that again now.
So as we close, Toby, thanks again for giving up your time and the contributions, and we hope you'll give us time to follow up in greater detail. We're going to have a roundtable discussion at the Live from Chicago meeting. We've already teed up a longer session and a deeper dive in our Live from Dingle Island meeting coming up in about a month's time, and those early bird tickets are available free online now. Get in. There's a few thousand people have already registered for that, so that'll be fun. And there was no signal. I'm not trying to suggest anything other than it's important for us to recognize both sides of the coin here. There was no signal of harm from the intravenous.
No, and I think that's a really important point. There was no difference in adverse event rates or severe adverse event rates, and no instance of harm or allergy seen with the intravenous iron. And there's been some speculation about some of the different iron preparations dropping patients' phosphate levels. We did see that, but it had no clinical relevance whatsoever because, as you can see from the trial, there was no difference in any aspect between the two arms. I am, however, going to leave you with one point hanging. The interesting thing about this trial is that we saw a huge difference between the hemoglobin levels at follow-up at 8 weeks and 6 months. Interestingly, that wasn't associated with a change in quality of life as measured by the MFI or the EQ5D. Now, I can't explain that because I really thought there would be.
And just to be clear, Toby, what we would expect, in other words, the IV iron patients had higher hemoglobins at follow-up. There was nothing counterintuitive there. There was no suppression or anything.
I mean, it's really dramatic. We as surgeons, as anaesthetists, we say goodbye to our patients, but I have no idea what the definition of a good rehabilitation or a good recovery is. They all come into clinic and go, I'm all right, doc, or not. And there you have it. But on average, those people who received placebo remained anemic to 6 months. That's quite a lot. And on average, those who received intravenous iron had their anemia corrected within 2 months and sustained to 6 months. So there's a big, big difference between the two. And we need to work out what that might mean. Because preoperative trials, getting someone into hospital 2 weeks prior to surgery, is really hard work.
Yes.
People talk about the utilization of iron, but I know from our clinics at UCH that over 1,000 people were getting iron every year, and most of them within the week before surgery.
Yes.
So the efficacy of this intervention appears to be in the postoperative period, and giving postoperative iron is really easy.
But was there any suggestion of a benefit from that? You suggested the fact the numbers were different, but the patients didn't notice it.
Yes, and that's the bit I'm hanging on to at the end. So there was a marked difference in readmission rates for complications between those who received intravenous iron and those who received placebo. So those who received intravenous iron were far less likely to be admitted with a postoperative complication and far less likely to have a follow-up infection.
Wow. Well, hang on a second, buddy. That sounds like really good news to me. Is it because that wasn't the stated primary outcome variable, you can't put that in flashing lights? Or?
Well, you have to think about the science here.
Yeah.
The question of the study was, if you give intravenous iron in the preoperative setting, do you correct the anemia and does the patient do better? The fact that 30 days after discharge you were less likely to be admitted to hospital, is that indicative to the iron being given 2 weeks prior to surgery?
Okay. But so let's imagine I'm running the health system now, and I'm responsible for that follow-up. I'm kind of like, you've just really got my attention again. Absolutely. Because the quantum associated with that overwhelms the quantum with regards to whether my patient gets a blood transfusion or not.
True, and I agree with you completely. So this is a secondary endpoint, but think about it from a scientific perspective. What determines whether or not a patient gets readmitted is highly subjective. We adjudicated those causality of readmissions, which were essentially one-liners on the ECRF. And luckily, we adjudicated it before data lock. in a blinded manner between two of us. So those definitions weren't clearly defined. So when someone said wound problem, we didn't grade that wound problem according to the CDC criteria for wound infection. So it's our interpretation of a one-liner that a nurse wrote in. Similarly, we didn't define the criteria for readmission. So this is it's a non-well-defined finding, and it merits further investigation. So
is that because, as you say, that would be we could give that iron on admission or prior to discharge, and if that turns out
as a clinical trialist, in a double-blind manner by the anaesthetist, as the skin is closed. And so the patient is double-blind, the surgical team is double-blind, but then you would have to have predefined secondary endpoints. So we're working hard on that at the moment. We're looking at what is the definition of a good recovery. So how do people recover? What is your sit-to-stand rate? What's your time to get up and go at 6 weeks? Is it different? Is it physiologically different? What's the mental change in the post-operative period? We know, for instance, a huge amount of data from intensive care medicine, but is that intensive care medical data for patients who've had 5 or more days on intensive care translatable to a patient undergoing major surgery who might recover much faster? So what's the validity of that inference? So before we all start giving intravenous iron post-operatively,
or possibly give up giving it preoperatively, from what you've just said.
Well, there doesn't appear to be benefit preoperatively.
But you just told me that the longer-term outcomes, I know the science behind this, Toby. We've just said it didn't cause harm, and there were fewer I'm kind of really interested in readmissions much more than whether or not they got a blood transfusion. But so when we follow up with this, we'll go into all of that in greater detail. But it sounds like there's a lot more head-scratching to be done.
I think, for the evidence-based perioperative medicine, which the name is on the tin, it is important, as I said, to stick to the hard facts.
The result is a result.
The result is a result. We have to respect the facts for what they are, even if I don't like them, even if you don't like them, even if colorectal surgeons don't like them. They are what they are. It's all the more reason for everyone to enroll into the ITAX trial. And all the more reason why, if you're going to institute any form of change in practice in healthcare, the data must be collected.
So as a parting thought for people, if you design the trial to say, does the preoperative administration of intravenous iron have an impact on readmission rates and post-operative long-term complications and post-operative hemoglobin levels, and you'd robustly measured and recorded those variables, you might have a positive result. But that's not the name of the game.
Well, that's exactly what I thought 10 years ago, Monty.
Right. Good. Toby, I really look forward to discussing this more. I really look forward to doing that in a room again at some stage, over a glass of diet lemonade or something, whatever it is.
I do miss academic discussions at conferences intensely. And, for me personally, this was 15 years of design. The first pilot studies were done in 2004, 2005. The first grant application went in 2010. After all this time, I presented it to a blank screen and my cat.
Yeah, so I remember some of the early discussions at UCL in sort of darkened rooms, and it was all going to be over by the Christmas after next. And I think the kids have grown up in between. So,
yes.
Toby, great. Thank you very much. Thank you, everyone, for listening. Please, I hope you get to watch this pre-record before we get to the roundtable discussion that we're going to have live from Chicago. A great panel there. I've no doubt there's going to be no shortage of opinions about how to interpret this trial. But as Toby says, this is evidence-based perioperative medicine. It is what it says on the can.
Anyone with an opinion could enroll into a clinical trial. No more opinions.
There we go. Let's get the T-shirt printed. Toby, thanks very much.
TopMedTalk. Nick Majerison here. Thanks for downloading TopMedTalk. TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. EBPOM has been advocating perioperative medicine for many years now, using the traditional conference circuit, where people have attended meetings from all over the world and heard some of the latest information. However, in the face of the COVID crisis, EBPOM took a bold decision. We've transposed the entire conferencing experience into an online experience. Carbon-friendly conferencing. The latest information, the latest talks, the hottest experts, the most incisive analysis, and even the socialising. We've got it all covered as EBPOM goes virtual. Hot on the heels of the huge success of EBPOM 2020 live from London, we're now headed towards EBPOM Chicago. Come aboard and be part of one of the most exciting developments in medicine since the stethoscope. EBPOM Chicago. Get yourself to ebpom.org now and guarantee yourself a place at one of the most exciting conferences in the world.